This conference will now be recorded.
So some of our competencies, we're going to apply fundamental knowledge to provide basic emergency care and transportation based on an assessment finding for an acutely ill patient. We're going to talk about decontaminating equipment and how to decontaminate the ambulance and equipment after treating a patient. We're going to apply fundamental knowledge of the EMS systems, safety and well-being of EMTs, medical legal practices, and ethical issues that affect patient care. We're going to talk about some standard safety precautions, some personal protective equipment. We're going to talk about stress management. We're going to talk about dealing with death and dying, the prevention of response-related injuries. We're going to talk about prevention of work-related injuries, lifting and moving patients, disease transmission, and principles of wellness and resilience. So to take care of others, we have to take care of ourselves. There's a lot of different facets that come into that. We're going to talk about all those coming up. So you got to recognize that there's a hazard. Personal neglect, environmental and human-made threats, mental and physical stress. All of those things can affect us as providers. Health is a complex interaction between your physical, mental, and emotional connections. Chronic physical, mental, or emotional stressors can worsen or increase the chance for developing health conditions. So if you're not taking care of yourself physically, mentally, or emotionally, that can develop into physical conditions. Not all of the reactions to stress are negative. So there is something called eustress, which is good stress, and it creates a positive response, versus distress, which is the negative stress response. So wellness is the active pursuit of a state of good health. And resilience is the capacity of an individual to cope with and recover from distress. Some of the ways we can do that, we can eat healthy and well-balanced diets. We can get 7 to 9 hours of sleep. And we can have positive relationships with our families and friends. At least 2 of those things, you're probably not going to see in EMS, but it's something we definitely need to work on as a career field. Building relationships with your peers and colleagues, incorporating daily stretching, movement, and exercise, and then habits of mindfulness and positivity. Managing stress. So let's work to minimize or eliminate stressors in your life. Let's change partners to avoid negative or hostile personalities. Change up your work hours for whatever works for you. Change your work environment if you need to. Cut back on overtime. You can change your attitude about the stressor. You can talk about your feelings. Seek professional counseling if you need it. Don't obsess over frustrating situations. And try to adopt a relaxed philosophical outlook. Expand your social support system. Develop friends and interests outside of emergency services. And limit the intake of caffeine, alcohol, and tobacco. Nutrition. Regular, well-balanced meals. Limit your consumption of sugars, fats, sodium, and alcohol. And maintain an adequate fluid intake. Again, those are things we're all bad at in this career field. Regular exercise enhances the benefits of good nutrition and adequate hydration. Good physical condition allows you to handle stress more easily. At least 30 minutes of moderate or vigorous physical activity 5 days per week. So let's talk about sleep. The National Sleep Foundation and the American Academy of Sleep Medicine recommend 7 to 9 hours of sleep per night. Half of EMS personnel get less than 6 hours of sleep per 24 hours and report severe mental and physical fatigue. Evidence-based guidelines for fatigue management have been developed under the U.S. DOT and through the National Association of State EMS Officials. Some of the recommendations to combat that fatigue: get adequate duration and quality of sleep. Take 20 to 30-minute naps during your shift. Increase your physical activity. Be careful about your caffeine consumption, and engage in mental exercise. Recommendations to improve your sleep quality: avoid caffeine and nicotine at least 4 hours before bedtime. Ensure your sleep environment is dark, quiet and cool. Exercise early and allow enough time to relax. Nap early. Avoid heavy pre-sleep meals and balance your fluid intake. You can establish a calming pre-sleep routine. Sleep when you're truly tired. Don't watch your clock. Keep a consistent sleep schedule and expose yourself to natural light during your waking hours. Disease prevention. Focus on medical care and prevention to avoid the effects of disease. Health promotion. You can focus on your personal practices and social habits to improve your health. Smoking, vaping, or chewing nicotine can lead to cardiovascular and respiratory illness as well as cancer. Strategies are available to assist with quitting nicotine-containing products. Alcohol abuse. Acceptable alcohol consumption is described to be 1 drink per day for women and 2 drinks per day for men. Excessive alcohol use can adversely affect many body systems and increase the risk of developing certain cancers. Drug use. Both prescription medications and illegal or illicit drugs may be abused or misused. Many EMS agencies drug test their employees for illegal and prescription drugs. So back on that, some of you guys in the class are from Maine. So what's one of the things that we might see that relates to that when we talk about illegal or illicit drugs? How about marijuana? Marijuana might be legal in the state, but that doesn't mean that, you know, in the EMS field it's necessarily approved or accepted. You know, if you were to come over the border and work in New Hampshire, it's not legal over here. So that's a problem you could face with drug use. So balancing your work, family, and health. Rotate your schedule so you can get some time off. Make sure you take vacations. And you got to seek help when the stress becomes more than you can handle. Infectious and communicable diseases. It's caused by organisms within your body, and they can be spread from person to person or from one species to another. You can minimize your risk of infection by getting immunizations, using protective techniques, and hand washing. Some of the different terminology for these infections: pathogens, contamination, exposure, and PPE. Some of the different routes of the transmission of these diseases: they can be direct contact, like a bloodborne pathogen; indirect contact, like getting stuck by a needle; airborne transmission, sneezing; foodborne transmission, contaminated food; or vector-borne, which is a flea or a bug or something like that. All EMTs are trained in handling bloodborne pathogens. The CDC has developed standard precautions, such as hand hygiene, and then gloves, gown, mask, eye protection, face shields, things like that. So the phrase donning your PPE, those of you that are firefighters, I'm sure you're familiar with that. Donning is putting on your PPE, where doffing is taking it off. You should perform that in a consistent sequence to reduce the risk of contamination. So, for example, don't take your dirty glove off and then touch your clean hand. Proper hand hygiene. Hand washing is the simplest yet most effective way to control disease transmission. And you should wash your hands before and after patient contact, even if you're wearing gloves. And when you're washing your hands, rub them together for at least 20 seconds to work up the lather. Pay particular attention to your fingernails, in between your fingers, and the back of the hands. If you don't have running water wherever you might be, if you're out in the field or something like that, you can use hand sanitizer. Most ambulances carry hand sanitizer right on them. If there's any possibility for exposure to blood or bodily fluids, you should be wearing gloves. Vinyl, nitrile, and latex gloves are effective. And like we talked about, when you remove the gloves, it requires a special technique to make sure that you don't contaminate yourself. Eye protection and face shields. Your eye protection is going to protect you from blood splatters and any other kind of splatters. Prescription glasses are not adequate for that. The fluids can still get around them. Goggles or some kind of face shield are going to be the best type of protection. Gowns, they provide protection from extensive blood splatter, and they can be worn in situations such as aerosol generating procedures, like a nebulizer treatment or putting someone on high flow oxygen, field delivery of a baby, major trauma, and more recently, COVID precautions. A standard surgical mask is good for your fluid splatters. You can put the surgical mask on the patient that might have a communicable disease like the flu or like COVID, for example. A mask with a particulate air respirator should be on yourself if we're talking about tuberculosis. Mouth-to-mouth resuscitation may transmit disease. Really, it says with an infected patient, but really with any patient, you should be using a pocket mask or a bag valve mask. And you'll want to dispose of them after the use. They're not multi-use. We don't wash them and reuse them or anything like that. Proper disposal of sharps. This helps to avoid any kind of like HIV or hepatitis transmission. We don't recap needles. We don't break or bend them. We dispose of them in a sharps container, an approved sharps container. There's no guarantee that you're going to be 100% risk-free. It's a hazard of the job. Follow OSHA and other national guidelines. Know your department's infection control plan and follow it. Infection control, it should be part of your daily routine, whether that's cleaning the ambulance at the beginning of your shift, after every run, whatever the case. And you should always be cleaning at the hospital. Don't wait till you get back. Clean it right away. Even if germs reach you, you may not become infected. You may have become immune to whatever it may be, whether that's the flu or something similar. Preventative measures: maintain your personal health and get your vaccines. The CDC recommends immunizations for Hep B, influenza, MMR, varicella, and Tdap. You can also get the skin test for tuberculosis. If you're exposed to a patient's blood or bodily fluids, turn over care to another EMS provider if you're able to do so. Clean the exposed area. If that area was your eyes, rinse them up to 20 minutes. Activate your department's infection control plan, and then make sure you fill out the exposure report after the fact. Begin protecting yourself as soon as you're dispatched. Make sure you continue that protection once you're on scene. Just because you're in the ambulance and you go to a car accident doesn't mean you don't need to put a vest on or other types of protective equipment, whatever you're provided. Hazardous materials. Identify what you can from a distance. Don't enter the scene unless it's safe to do so. Electricity. It's beyond the scope of our training. Mark off a danger zone. Light it up so that nobody else can get near it. Fire hazards. If you're working on an ambulance, if you're in the EMS side of things, you're not prepared for the smoke-filled atmosphere, oxygen-deficient atmosphere, high temperatures, toxic gases, building collapse. You may not be wearing your full gear that you would normally be wearing if you were functioning as a firefighter. Be aware of that. Vehicle crashes. It's common for EMS providers. There's traffic, unstable vehicles, could be power lines down, sharp objects. Violent scenes, assaults, hostage situations, riot situations, any kind of mass violence. Know who's in charge. Remain vigilant for potential violence. Allow law enforcement to clear the scene before you get there. And at scenes involving projectiles, find protection. Cover yourself and conceal yourself. To prevent violence, training and practice identifying the scenes and sources of potential violence. Training and practice with de-escalation. Training and practice improving interpersonal communications. And then dispatch identification and alerting of past or potential threats of violence. Training and practice in self-defense and escape techniques. Train and practice physical and chemical escape techniques. Fitting and use of body armor. And practice operations with your law enforcement agencies. Your protective clothing, it's critical to your safety. You should be familiar with whatever your agency has. Cold weather, make sure you're layered up. If you're wearing turnout gear, heat, fire, sparks, and flashover, some of the different protection you get from that. Gloves, and whether that be a firefighting style glove, an extrication style glove, just a general utility glove, or even your medical gloves, it all applies. Helmets, if there might be any falling objects, and steel toe boots. Eye protection, glasses with a side shield. Ear protection, some foam earplugs. Sunblock, and vests, body armor style vests. How many of you guys work for an agency that has body armor? I see a few of you. So that's the new up and coming thing. Caring for critically ill and injured patients. Let the patient know who you are and what you're doing. And let the patient know that you're attending to their immediate needs. It's very, very, very important that you're communicating with these patients. They need to know what's going on. At that moment, that patient is having the worst moment of their life, and you being able to communicate with them effectively and tell them what's going on and reassure them that you're going to help them can change the entire atmosphere. Avoid sad and grim comments. Don't walk up and say, oh, that looks bad. That doesn't do the patient any good. Orient the patient. Let them know where they are. Let them know what's going on around them. Be honest with them. We're going to move you and this is going to hurt. Don't sugarcoat it. They need to know the truth. Deal with possible initial refusals of care. So you approach these patients, they immediately say, I'm not going to the hospital. Work through that. Don't accept that as, okay, we're leaving. Work through that with them. Talk them through that. Talk about some of the different options with them. Allow for hope and locate and notify family members if you're able to do so. Injured and critically ill children. You need a responsible adult to accompany the child. And the death of a child, it's a tragic event. It's going to be tragic for you as a provider. It's going to be tragic for your partners. It's going to be tragic for the family members. Let the family's actions be your guide, but once you've determined that there's no resuscitation effort, your focus is now on the parents. They're now your patients. They're your new patients now, and you've got to work them through this. There might be brothers, sisters. It doesn't matter. There could be anybody there. Your job is to keep them calm and work them through this. Death and dying, it occurs quite suddenly, and it could occur after a prolonged terminal illness. And, those are two very different things. The sudden death, it's unexpected. Nobody knew it was coming. That's where you're going to have to deal with grieving parents and things like that. Prolonged terminal illness doesn't make it any easier. They may have had a heads up it's coming, but they're still going to be grieving. And the EMT's going to face death. Unfortunately, it's a sad reality of this job. You're going to see it. It's going to happen. Some of the different stages of the grieving process: denial, anger and hostility, bargaining, depression, and acceptance. The EMT's role in all this: ask them how you can help, reinforce the reality with them, be honest with them, and allow them to grieve. Some of the suggested words of comfort: I'm sorry for your loss. It's okay to be angry. It must be hard to accept this. This must be painful for you. Tell me how you're feeling. If you want to cry, it's okay. People really cared for the individual. EMS is a high-stress job. It's important to know the causes of stress and how to deal with those causes. General adaptation syndrome, you have an alarm response to stress, reaction and resistance, recovery or exhaustion. The physiologic signs of stress: increased respirations, increased heart rate, increased blood pressure, cool, clammy skin, dilated pupils, tensed muscles, increased blood glucose level, perspiration, decreased blood flow to the gastrointestinal tract. Dangerous situations, physical and physiological demands, critically ill or injured patients, dead and dying patients, overpowering sights, smells, and sounds. Those are all things that are going to create stressful situations in your mind. Anytime you have multiple patients, angry or upset patients, families, or bystanders. Unpredictability and demands of EMS. You never know what your day is gonna come. Acute stress reactions occur during a stressful situation. Delayed stress reactions manifest after the stressful event. And then cumulative stress reactions, it's a prolonged or excessive stress. After a while, you finally break. Some of the physical symptoms of stress are fatigue, changes in your appetite, GI problems, headaches, insomnia or hypersomnia, irritability, inability to concentrate, hyperactivity or underactivity. Psychological symptoms: fear, dull or non-responsive behavior, depression, guilt, oversensitivity, anger, irritability, and frustration. Critical incident stress is caused by acute severe stressors, such as mass casualty incidents, serious injury or traumatic death of a child, crashes with injuries caused by an emergency provider while traveling to or from a call, death or serious injury of a coworker in the line of duty. Post-traumatic stress disorder, PTSD. It may develop following a psychologically distressing event. It's characterized by re-experiencing the event and over-responding to the stimuli that recall the event. Critical incident stress management. That's a program that's used to help providers relieve their stress. It can occur formally or at an ongoing scene. It's facilitated by trained professionals. Burnout. It's a combination of exhaustion, cynicism, and reduced performance resulting from long-term job stress. It affects the well-being of the EMT, along with that of the crew members and patients. Compassion fatigue. It's also known as secondary stress disorder. It's characterized by gradual lessening of compassion, and some of the symptoms can be high absenteeism, inability to work in a team, lack of empathy for patients, and a judgmental attitude towards patients. Responders' risk for suicide. The suicide rate among emergency responders is higher than the rest of the population. The job stress is considered to be the largest contributing factor to suicide. There's several organizations and mental health services available to provide emotional support. The emotional aspects of emergency care. At times, healthcare providers have trouble overcoming personal reactions and proceeding without hesitation. The struggle to remain calm in the face of a horrible circumstance contributes to the emotional stress. Many factors influence how a patient reacts to the stress of an EMS incident. Quickly and calmly assess the actions of the patient, the family members, and the bystanders. Always use a professional tone and show courtesy. Allow the patient to express their fear, and respect any religious customs and needs. Cultural diversity. You're going to work with coworkers of different backgrounds, beliefs, values, and this could be their nationality, their age, their disability, their sex, their sexual orientation, their marital status, work experience, their education. You got to communicate with everybody in a way that's sensitive to everyone's needs and always remain open-minded. Two different types of sexual harassment: quid pro quo, which is a request for sexual favors, and hostile work environment, which is jokes, touching, things like that. Any type of harassment needs to be reported to your supervisor immediately. Keep detailed notes of whatever's going on. Substance abuse. It increases the risk on the jobs. It leads to poor decision making. You got to seek help or find a way to confront somebody that you know is going through this. Most companies do have employee assistance programs to help an employee through this kind of stuff. Injury and illness prevention. Most agencies have a program like this. It should have management leadership, worker participation, hazard identification and assessment, hazard prevention and control, education and training, and the program should be evaluated and improved upon on a regular basis. So we've almost made it through the first one. So a disease that can be spread from person to person, what do we call that? So the answer is B, communicable disease. It can be spread from one person or one species to another. The most effective way of preventing the spread of disease. That's right. A, hand washing. While caring for a trauma patient, the EMT has blood splashed into her eyes. What is this an example of? That's right. B, exposure. Protective measures that prevent healthcare workers from coming into contact with germs are referred to as B, standard precautions. What is the second stage of response in the stress response known as the general adaptation syndrome? That's right. D. A condition characterized by re-experiencing an event and over-responding to stimuli that can recall the event is called what? Yeah, very good. D. PTSD. Fuel to make the body run. C. Food. Food's going to be your fuel. Which stage of grieving commonly results in blame? B. Anger and hostility. Placards are used on what? A. Buildings or transportation vehicles. The 5 most common hazards associated with a structural fire. A. Smoke, oxygen deficiency, high ambient temperatures, toxic gases, and building collapse. All right, that's it for this chapter. So let's take 10 minutes, take a quick break. I'll get the next one loaded up. We'll go from there.
This conference will now be recorded.
All right, so now we're going to talk about medical legal. So this is a pretty in-depth one, so we'll go through this the best we can here. So some of the things we're going to talk about consent. We're going to talk about refusal of care, confidentiality, advanced directives, tort and criminal actions, evidence prevention, and statutory responsibilities, mandatory reporting, ethical principles and moral obligations, and end-of-life issues. A basic principle of emergency care is to do no further harm. A healthcare provider usually avoids legal exposure if he or she acts in good faith and according to an appropriate standard of care. Consent is permission to render care. A person must give consent for treatment. If the patient is conscious and rational, he or she has the legal right to refuse care. So this is a very loaded item here. You can't assume that every patient wants to be treated. And if they're of sound mind and sound decision-making capacity, they can refuse treatment. But you've got to check your boxes and make sure that you've verified whether or not they're capable of making that decision in an informed manner. The foundation of the consent is that decision-making capacity. They need to be able to understand what you're telling them, and they need to make an informed choice regarding their medical care. Patient autonomy is the right of the patient to make decisions about his or her health. So if the patient can understand what you're telling them and they understand the risks, they're eligible to refuse care or consent for care, either way. Expressed consent. So this is when the patient acknowledges that he or she wants you to provide care or transport. To be valid, the patient must provide informed consent. So you've explained the treatment, the risks, and the benefit to the patient, and they're expressing their consent for you to provide the treatments or transport. Implied consent. So this is for patients that are unconscious and patients that are incapable of making an informed decision. So this would be a patient with an altered mental status, or a patient that's impaired by alcohol or drugs, a patient with an extremely low blood sugar who's not making sense. Any of those things would affect their ability to consent or refuse. Implied consent should never be used unless there's a threat to life or limb. The principle of implied consent is known as the emergency doctrine. Try to get consent from a spouse, a relative, a caretaker, somebody that's with the patient that knows the patient. Try to get them to give the consent for the patient to be treated or transported. Involuntary consent. So this applies to patients that are mentally ill, patients that are in a behavioral crisis, or developmentally delayed. You're going to want to obtain consent from a guardian or a conservator. It's not always possible. You got to understand local protocol, and this is a great opportunity to have medical control, a doctor at the hospital, on the phone, and talk it through with them, and work out something that's going to be tenable for everybody, for the providers and for the patients. You'd also want to have law enforcement involved if you're going down this route. Minors and consent. The parent or legal guardian has to give you the consent. In some states, a minor can give you consent, and emancipated minors can also give consent for themselves. And emancipation typically happens when a child has become married, or they're in the armed services, things like that. or if they have children of their own, they become emancipated as well. Teachers and school officials can also act in place of a parent. Sometimes you can even extend that out to like a summer camp counselor, things like that. They've kind of taken the role of a guardian for the child at that point. If you cannot get consent from anybody and a true emergency exists, treat the patient. Implied consent works here. Again, not a bad time to get medical control involved if you have the time to do so. Forcible restraints. Sometimes it's necessary with a combative patient. It is legally permissible under the right circumstances. You should always consult with medical control before you restrain somebody, and it may require law enforcement, but it's in your best interest to have law enforcement present. Once you've applied any kind of a restraint to a patient, you do not remove them unless they pose a risk to the patient. For example, if you have a patient restrained and they start to seize, you may need to remove those restraints so they don't hurt themselves any further. And you should consider calling ALS backup to provide chemical, pharmacological restraint. They can medicate the patient to calm them down. The right to refuse treatment. Conscious, alert adults that have decision-making capacity have the right to refuse treatment. They can also withdraw from treatment at any time, even if it would result in death or serious injury. The calls that involve a refusal are frequently litigated. These calls go to court all the time. You should always involve online medical control and document the consultation. This is a great time when you have a patient who really needs to go to the hospital, they really need treatment, and they're saying, I'm not going to go and you can't make me. Get the doctor on the phone at the hospital. Explain, doc, this guy needs to go to the hospital. These are the reasons why I feel he needs to go to the hospital. Put the doctor on speakerphone and let the doctor talk to the patient. Sometimes hearing it from a doctor will change their perspective on it. Sometimes that will encourage them to, okay, if a doctor's telling me I need to come in, maybe I will. You're going to need to assess the patient's ability to make the informed decision. Ask and repeat your questions. Assess their answers and observe the patient's behavior. So ask them questions. Are their answers to your questions changing? Do their answers make sense? Observe their behavior. Are they acting erratically? Are they acting bizarre? If the patient's confused or delusional, you can't assume that it's an informed refusal. They may not understand what you're telling them. They may not understand the risks of not going to the hospital. Providing treatment is a much more defensible position than failing to treat a patient. However, don't endanger yourself. Use the assistance of law enforcement and medical control. What they're trying to say here, providing treatment to a patient who said they didn't want treatment is a lot easier to defend than just leaving somebody out there to die. Before you leave a scene where a patient, parent, or caregiver has refused care, encourage them to allow care. Just keep trying. Be persistent on it. Ask the individual to sign your refusal form. If there's a witness there, have a witness sign as well, whether that's the patient's wife or a child or an adult child, that is, law enforcement, a firefighter on scene. It really shouldn't be your EMS partner, your partner on the ambulance, but anybody that's not your partner that is on scene and witness the patient telling you that they're not going to go should sign that form. And you have to document all your refusals, just like you would for any other call. You need to write a patient care report, and your refusal reports should be significantly longer than your transport reports. You need to put a lot more detail into it. You need to document, what you told them, the different ways you tried to get them to go to the hospital, all that kind of stuff. It's only going to save you later if this goes to court. If something happens to that patient and you didn't accurately document that you tried to get them to go to the hospital, it could come back on you. Confidentiality. Confidential information includes patient history, your assessment findings, and the treatments you provided. You typically cannot disclose any of the information unless the patient is signed a release, a legal subpoena is presented, or it's needed by billing personnel. HIPAA, the Health Insurance Portability and Accountability Act of '96. It contains a section on patient privacy, and it strengthens privacy laws. It safeguards patient confidentiality, and it considers the information to be protected health information, or PHI. Failure to abide by the provisions of the HIPAA laws can result in civil and criminal action. The general public is often permitted by law to record identifying and protected patient information and images. General public can do it, we can't. Social media. Avoid your agency logos, uniforms, vehicles, other markings while you're off duty. Conduct yourself professionally on and off duty, and your freedom of speech does not mean that everyone has a right to say anything under any circumstances and without repercussions. Yes, you have the freedom of speech, but that doesn't mean there won't be repercussions for that freedom of speech. Don't post pictures of car accidents with patients present. Don't post pictures of car accidents with license plates in them. It's not professional. It's not the right thing. Would you want to find out that one of your loved ones was involved in a car accident because you see it on TikTok or Facebook or anywhere else? Just think about that end of it. You know, those of us that are fire nerds, you know, we love to take pictures of buildings on fire and things like that. There's a family on the other side of that fire. There's people that own that house whose belongings are burning in front of your eyes, and those photos are being used for your own glory. You've got to think about that aspect of it before you post these on social media. Advanced directives. So an advanced directive specifies treatment should the patient become unconscious and unable to make decisions. A do not resuscitate order is an advanced directive that gives permission not to resuscitate the patient. However, do not resuscitate does not mean do not treat. Do not resuscitate simply means that if they are coding, if they do not have a heart rate and they are not breathing, they do not want to be resuscitated. They do not want CPR. You still would treat them for any other condition. If they had a low blood sugar, you're still going to treat that. Just because they have a DNR, it doesn't mean you're not going to do anything for them. Other names for advanced directives, some people call it a living will, and it can also be called a healthcare directive. Your DNR orders must meet the following requirements. They have to have the patient's medical problems. They have to be signed by the patient or the patient's legal guardian. They have to be signed by a physician or a healthcare provider, and they cannot be expired. Here's an example of a medical care directive. In New Hampshire, they're pink. They're a fluorescent pink color, and the patients are told to keep them on the fridge. So back on DNRs, if we don't have it, if they can't present it, you can't honor it. If they don't have a valid DNR that they can hand you, we can't honor it. You can involve med control in that decision, and you can call med control and say, hey, the family's here. They're saying this patient does not want to be resuscitated. The doctor can order you to not resuscitate. However, if they can't present the paperwork, you can't prove there's a DNR. Physician orders for life-sustaining treatment, or a POLST, and medical orders for life-sustaining treatment, a MOLST. They explicitly describe acceptable interventions for the patient. They must be signed by an authorized medical provider, and you can contact MedControl for guidance. So these are the documents that list specific things that the patient does or does not want to receive. And that can be driven by medical, that can be driven by religious beliefs, whatever the case. But, you know, this may say that a patient does not want IV rehydration, which would be out of the EMT scope, but you know that basically says they don't want an IV and they don't want to receive fluids. These documents would describe what they do and do not want to receive for treatments. Some patients may have named surrogates to make decisions for them. That could be known as a durable power of attorney or a healthcare proxy. You might face that, especially with hospice patients who are they basically elected to pass away at home. a lot of times it's their children or a close friend, something like that. That person, there's a legal document that says that person can make their medical decisions. Again, they need to have that paperwork. Physical signs of death. So a physician is going to determine the cause of the death. Some of the presumptive signs of a death. One of the questions in the chat, what about a DNR bracelet? That's kind of a gray area. I could go on Amazon right now and order a bracelet that says DNR, and I could wear that on my wrist. That doesn't mean that I have the document that's signed by a doctor. Your best course of action, if you're presented with something like that, would be to contact medical control and tell them what you're looking at. Hopefully there would be family there that you could speak with family and kind of determine, do you have the documents? Do you not have the documents? Medical control is going to be your lifeline for that, and let them make the decision. I would not treat a DNR, personally, I would not treat a DNR bracelet as a valid document because, again, there's no signatures there, there's no names there. You can't even prove that it's their bracelet, really. Did that answer that question? Okay. Physical signs of death. Some of the presumptive signs: unresponsiveness to painful stimuli. So sternum rubs, things like that, they're not responding. Lack of a carotid pulse or heartbeat. Absence of breath sounds. And there's no deep tendon or corneal reflexes. Their eyes aren't moving. They're not moving any of their extremities. No movement. Absence of eye movement. No systolic blood pressure. Profound cyanosis. So they're going to be very, very, very blue throughout their entire body. Lowered or decreased body temperature. Definitive signs of death: a body in parts, decapitation, any kind of missing parts. Dependent lividity, which is the blood settling, which is the photo you guys can see on the right. You're going to see it, in a patient that's passed away, if they're laying down, you're going to see it on their back like this first. A lot of times, you're going to want to roll them over. You're going to want to look at their underside. If it's not obvious looking at them from the front, you're going to want to look at their underside. And if you see this, you can see all the blood is settled in one spot, and that's what's causing that darkened mass in the lower back. As time progresses, their entire body is going to start to show some of these same signs. Rigor mortis is the stiffening of joints. 2 to 12 hours after their death, you're going to start to see this. So this is going to be when you try to pick up their arm, and their arm won't move. It's locked in place. That's called rigor mortis. Algor mortis is a cooling of the body until it reaches the ambient temperature of the environment. These are going to be the patients that feel ice cold. Putrefaction, which is decomposition, that's going to be 40 to 96 hours after death. Weather can affect that. In the winter months, if they're in a cold environment, you're not going to see it as quickly as you would when it's hot outside. The involvement of the medical examiner is going to depend on the nature and the scene of death. Typically in EMS, we're not going to be the ones making this call. Typically, once we've determined that we're not going to resuscitate, we turn the scene over to the police and they make these calls. Most of the time, though, they are notifying the medical examiner. That's going to happen in cases of dead on arrival, dead on scene, death without previous medical care, suicides, violent deaths, and poisonings. Death from accidents, any suspicion of a criminal act, and then infant and child death. Some special situations: organ donors. This would be an individual that's expressed a wish to donate their organs when they pass away. And some of the things you might see, again, back to bracelets. They could have a bracelet. It could be on their driver's license. They might have an organ donor card. Your priority is to save the patient's life. Organs do need oxygen to survive. In the field, we are typically not going to continue to do CPR on a patient just for their organs. That is not typically something that we would do. Here's an example of an organ or tissue donor card. On this, they can specify whether it's any organs or just specific organs. And there's the bracelet, necklace, keychain, or card that indicates a DNR, allergies, diabetes, epilepsy, other medications. Some patients wear a medical bracelet with a USB flash drive. I've also seen them nowadays with a QR code that you can scan with your phone, and that'll bring up a card of their medical history. There's an example of a medical bracelet. So your scope of practice. This is going to outline the care that you're able to provide at your level. It's usually defined by state law. It varies state to state, and your medical director can further define it by developing your protocols and your standing orders. Carrying out a procedure that's outside your scope of practice can be considered negligence, and it can be considered a criminal offense. The standards of care dictate the ways you must act or behave. You must be concerned about the safety and welfare of other people. Standards of care are established by local customs, laws, by statutes, ordinances, administrative regulation, or even case law. Professional standards, such as American Heart Association CPR guidelines, and textbooks as well. Medical Practices Acts, certifications, licensure, credentialing, all that stuff that the states impose on you. Each state has its own set of protocols. Each state has its own standards for certification and licensure. Duty to act. So this is an individual's responsibility to provide patient care. And it applies once your ambulance responds and once treatment is begun. In some states, just having that little plate on the front of your car that identifies you as a first responder can actually rope you into having a duty to act. Be cognizant of that. Be cognizant of driving by a car accident in a vehicle that has that silly little plate on the front that says you're a firefighter or an EMS provider. Negligence. It's failure to provide the same care that a person with similar training would provide in the same situation. There's 4 things that have to be proven for negligence to apply. Duty, meaning you had a duty to act or a duty to perform something. The breach of duty, which means you chose not to do it. Damages must have been caused, and causation. I'm not even going to try to say that first one. The cause of the injury was in the control of the EMT. It generally doesn't occur unless there's negligence. Negligence per se, the conduct of the person being sued is alleged that it occurred in a clear violation of a statute. And then torts are civil wrongdoings. Abandonment. Unilateral termination of care by an EMT without the patient's consent and without making provisions for continuing care. An abandonment could take place at the scene or in an emergency department. Always obtain a signature on your patient care record, whether that's for a transport or for a refusal. Make sure you're getting your signatures. It shows that care has been transferred. Abandonment, another situation that can come into play. If you're on your way to a call and a call comes in that sounds better, you're going to a medical call and a structure fire comes in, and we want to play fireman today, so we're just going to turn around and go the other way to the structure fire. You were already committed to a call. You were already on your way to a patient. If you're not making provisions for somebody else to take care of that patient, you could be held responsible for abandoning that patient. You've got to be very careful with that. Assault, battery, and kidnapping. Assault is unlawfully placing a person in fear of immediate bodily harm, for example, restraining them. Battery is unlawfully touching a person, providing a care without consent. Something as simple as trying to take a blood pressure without them allowing you to do it could be considered battery. Kidnapping is seizing, confining, abducting, or carrying away by force. For example, they say they don't want to go to the hospital, and you pick them up and put them in the ambulance and go anyway. You've now kidnapped them. False imprisonment would be unauthorized confinement of a person. Along those same lines, you've confined them to that ambulance and they don't want to be there. Defamation. This is communication of false information that damages the reputation of a person. Libel can be written and slander can be spoken. Good Samaritan laws and immunity. If you reasonably help another person, you're not going to be held liable for errors or omissions. Good Samaritan's conditions must be met. You must have acted in good faith, without expectation of compensation, within the scope of your training, and you didn't act in a grossly negligent manner. Meaning, you did what you thought was right. You weren't expecting that the patient was going to give you a tip for doing a good job. You acted within the scope of your training, and you weren't negligent in your actions. Gross negligence is conduct that constitutes willful or reckless disregard. Immunity statutes apply to EMS systems that are considered governmental agencies. Sovereign immunity provides limitations on liability, and immunity is not complete. Records and reports. Compile a record of all the incidents that involve sick or injured patients. You should be writing a report for any call you respond to, whether there's a patient or not. In some states, that's part of your protocol. In New Hampshire, it is. It's an important safeguard against legal complications. The courts consider that an action not recorded was not performed. If you didn't document it, it didn't happen. That's how it works. You can't go back later and say, oh, well, I actually did check that patient's blood sugar. I just didn't document it. It doesn't work that way. Incomplete or untidy reports is evidence of poor emergency medical care. If you write a one-sentence report after you transport somebody, you're not writing a good report, so who's to say you provided good patient care? The National EMS Information System, or NEMSIS, it provides the ability to collect, store, and share standardized EMS data, and it's used to improve the speed and accuracy of data collection. So when you write your reports in your state's reporting system, they all get sent up to NEMSIS, to the national system. Most states have a reporting obligation. This is for abuse of children, older persons, special needs, injury during the commission of a felony, drug-related injuries, and childbirth. Most states, if any of these things occur, you're required to tell somebody about it. If you're aware that a child or an older person or somebody with special needs is being abused, you have to call somebody about that. If somebody was injured during the commission of a felony, so they were doing something stupid with a firearm and they shoot themselves, you have to report that injury. Drug-related injuries, you got to report it. If a child is born, you got to report it. Hopefully they're going to the hospital at that point, but it's got to be reported. Attempted suicides, dog bites, communicable diseases. So if you're exposed to somebody's blood or somebody else has been exposed, you've got to report that stuff. Assaults and domestic violence. Sexual assault or rape. Exposures to infectious disease. A transport of a patient that's in restraints. The scene of a crime and the deceased. All these things have to be reported on. Your ethical responsibilities. Ethics is the philosophy of right and wrong, your moral duties, and your ideal professional behavior. Morality is a code of conduct that affects your character, conduct, and conscience. Bioethics specifically addresses the issues that arise in the practice of healthcare. You have to evaluate and apply ethical standards, both your own and those of the profession in general. Rules, laws, and policies need to guide your decision making. You could end up in court, and it could be as a witness or you could be a defendant. Could be civil or it could be criminal. If you're called to testify, you got to tell your service director, your chief, and you're going to need to notify legal counsel, whether that be a representative of your town employment or whatever the case. Whether you hire your own, you're going to need legal counsel. If you're going in as a witness, remain neutral. Review your run report before you go to court. Know your run report in and out because they're going to pick it apart. If you're going in as a defendant, your attorney is going to be required. Defenses might include things like statute of limitations, governmental immunity, contributory negligence. Discovery allows both sides to obtain more information through interrogatories, which are written requests or questions, or depositions, which are oral requests or questions. Most cases are settled following the discovery phase and during the settlement phase. If it's not settled, the case goes to trial. They can award different damages. They can give them money. They can give them all kinds of different things like that. An EMT that's charged with a criminal offense should secure the services of a highly experienced criminal attorney immediately. All right, we're at the review. So you arrive at the scene of an older woman who's complaining of chest pain. In assessing her, she holds her arm out for you to take her blood pressure. This is an example of the answer is C, expressed consent, also called actual consent. The patient's authorizing you to provide the treatment and transport, either verbally or non-verbally. So implied consent is limited to life-threatening emergencies, and it's appropriate when a person's unconscious or delusional. Informed consent is when you've told them the risks and benefits and they've decided to allow it to happen. And emergency consent is not no. Which of the following is an example of abandonment? Very good. D. Unauthorized confinement of a person. Very good. False imprisonment. Failure of the EMT to provide the same care as another EMT with the same training. Very good. C. Eight-year-old boy struck by a car. He's unconscious. He's bleeding from the mouth. Police officer tells you he's unable to contact the child's parents. What should you do? Good. A. The child is critically injured and requires immediate treatment and transport. Waiting until his parents are contacted, it wastes time and it increases the chances of a negative outcome. An advance directive. What is it? Good. C. It's a written document signed by the patient and a witness. Which of the following patients is competent and can legally refuse EMS care? Very good. C. So our confused female, she says she's the president. Is her mental condition intact? Doesn't appear so. Man is staggering and states that he drank 3 beers. He admitted to alcohol on board. He can no longer make his own medical decisions. Diabetic patient with slurred speech and is not aware of the date. He's not alert and oriented. He can't make his own decisions. You're treating a patient with an apparent emotional crisis. After the patient refuses treatment, you tell him that you will call the police and have him restrained if he does not give you consent. Your actions in this case are an example of what? Unlawfully placing a person in fear of immediate bodily harm constitutes assault. Very good. The EMT has a legal duty to act if he or she is what? The answer is B. EMT paid or volunteer. Legal duty to act if she's on duty and responded to a call. Or is dispatched to a call, I apologize. Which of the following statements about records and reports is false? All right, so this one's going to be D. Your patient care report does become part of the patient's permanent hospital medical record. Even though it happened outside the hospital, they still take your report and attach it to their medical record. All right, we've hit our 2 chapters. Anybody have any questions?